Hello everyone, good evening, bienvenue to the EUROGEN webinar programme. I'd just like to take a couple of minutes to tell you about what a European reference network is. We're essentially networks of highly specialised healthcare providers and clinicians who treat patients with rare and complex diseases. And of course, one of the diseases that EUROGEN covers is bladder exstrophy. And of course, this is an area where we really profit from bringing together the European leading experts, and they're sharing knowledge on how to treat these patients as well as we possibly can. So it's an absolute delight to have here with us this evening, not one, but 4 experts. So today we have with us Professor Alaa El-ghoneimi from the University of Paris, Robert Debré Hospital. We have Professor Marc David Leclair from Nantes University Hospital. And we have Professor Henri Lottman from the University of Paris Necker Hospital. And then finally, Thomas Blanc from the University of Paris Necker Hospital. So once again, gentlemen, thank you so much for being here this evening with us and sharing your expertise. Please, the audience, feel free to ask questions at the end. And we thank you very much for attending. Have a good evening. And I'll hand over now to the 4 experts. Thank you so much.
Good evening, everybody. I am Thomas Blanc, pediatric urologist at Necker Malade Hospital in Paris. It is my great honor and pleasure to welcome you at the eUROGEN webinar, Management of Bladder Exstrophy During Childhood. I'm very happy to welcome 3 top panelists: Alaa El-ghoneimi from Robert Debré Hospital in Paris, Marc David Leclair from Nantes, and Henri Lottman from Necker Malade Hospital in Paris. So the webinar will focus on the bladder management in exstrophy patients with 3 goals. We won't talk about genitalia today. First goal, we will discuss the age and the type of closure. Second goal, we will explain the management of complication after closure, such as dehiscence, UTI, and dilatation of the upper urinary tract. And third goal, we will discuss about the management of persisting incontinence. So the goal number 1 is to determine the age and the type of closure. In this slide, you can see 2 baby boys with bladder exstrophy. On the left, a small bladder template, and on the right, a large bladder template. The timing of bladder closure is a subject of both debate and speculation. The closure can be done in the first few days of life, and osteotomy can be avoided if the pelvis can be easily opposed. Neonatal closure may have a positive effect on bladder growth, thus ultimately influencing a patient's ability to achieve continence. And neonatal closure minimizes potential damage to exposed bladder mucosa. But neonatal surgery may have deleterious consequences. That is why there is a trend to delay the closure between 6 weeks to 4 months, and the benefits may include stretching of the template in case of small bladder template, planned surgery with expert surgeon, early postnatal parental baby bonding through breastfeeding and direct contact, and complete reconstruction is possible during or just after mini-puberty. In our 3 centers, we used to do neonatal closure without osteotomy, with an incidence of less 3% of bladder dehiscence. Dehiscence is thus a rare complication after neonatal closure without osteotomy. However, our strategy has recently changed. In the 2 centers in Paris, we switched from the modern stage repair with 3 steps to the delayed complete primary reconstruction. In Nantes, the strategy used to be closure plus radical soft tissue mobilization in 2 stages. Now, Marc-David Leclair moved to closure combined with scaly repair in 1 stage. Why change from neonatal closure to delayed closure? If you consider the area of Paris, with the incidence of bladder exstrophy of 1 out of 50,000, it means that there are 3 new cases per year, with 17 children between 2015 and 2019. The 2 main objectives of this evolution of strategy are to gather different teams for each bladder exstrophy closure and to strengthen the training for the new generation of fellows with common protocol, peri-operative management, and post-operative follow-up. So what is the preoperative management for a delayed closure? Blood test, creatinine, hemoglobin, renal ultrasound, which is the most of the time normal, spinal cord ultrasound in case of spinal epidural anesthesia, echocardiography as heart defects are present in 6% of exstrophy epispadias complex patients. There is no consensus in the literature for preoperative testosterone stimulation of the phallic size. There is no consensus for bladder plate protection. In Paris, we do not protect the templates, but Marc-David will explain us his protocol.
I think indeed that it's important to protect the mucosa of the bladder from the mechanical trauma. What we use is these non-adherent silicone interface dressing like Mepitel or Adaptic or anything. It doesn't have to be sterile. It doesn't have to be changed many times a day, but at least it can be repositioned and it protects the mucosa from all the mechanical trauma. I think it's even more important to protect the skin from maceration due to urine stagnation. I use a protective cream made of silicone and paraffin, like the ones we use for colostomies. And I think it's extremely important to pay attention of any sign of skin inflammation, which could indicate fungus infections, because undiagnosed preoperative candidiasis of the skin could get you into troubles after surgery. So I tend to protect the skin very well before surgery.
Thank you very much. So in Paris, we have moved to a complete primary reconstruction with closure of the bladder, loose bladder neck reconstruction, and epispadias correction. Urethral implantation if the bladder is suitable, anterior innominate osteotomy, and immobilization with an external fixation, and Alaa will describe his technique.
Yes, this is our consensus about fixation, that they put already, they do the anterior innominate osteotomy bilateral, our orthopedics, and then we put 3 tige for every any side, and then you fix the osteotomy, and then we keep in, we don't put any more children in intensive care unit since we use the peridural, and then after a few days we keep them in the department with the first 3 post-operative weeks with a traction, 5 kilogram of traction, and then after 3 weeks they go home with what you can see, that spica, which is a light one, and they go home with external fixation, and then they come back 6 weeks after.
Thank you very much. And Marc-David will describe the management in Nantes.
Okay, so we've been doing the Kelly technique in Nantes for the last 12 or 13 years now for reconstruction of bladder exstrophy and incontinent proximal epispadias. As you all know, the Kelly implies a complete mobilization of the corpora from the pelvic bones, but also of all the the attachments of the anterior pelvic floor, which allows a reconstruction of the urogenital structures independently of the pelvis. We perform a gentle bladder neck reconstruction at the same time, which is not exactly a cervicoplasty. It's more a tubularization of the posterior urethra surrounded by skeletal muscle. I try to perform urethral vesicle reimplantation each time it is possible, and most of these children can be closed without osteotomy, exactly because it is a radical mobilization. But when necessary, in case of major diastasis, I like to do a pubic anterior osteotomy through the obturator frame. And in most boys, urethral meatus is placed in hypospadias position. Next, I think you'll see some videos of the technique. On the first video, it shows you the degree of mobilization you can achieve after extensive dissection. Both corpora have been lifted from the istiopubic bones, and one can use muscle stimulator to show the bulbous spongiosus muscles. On the second video, this is the illustration of why disconnection of the urethral plate is necessary. It allows you to place the bladder neck within the pelvis and to keep all the penile length on the outside at the same time. And the last video is the result once everything has been tubularized and muscles wrapped around the urethra.
Thank you very much. So the second goal of the webinar is to discuss of the management of complication after closure. As we said, bladder dehiscence is a rare complication after closure. And in case of dehiscence, a redo closure is needed. The onset of dilatation of the upper urinary tract and or UTI is common. We will discuss two observations. The first case is a 2-year-old girl with a prenatal diagnosis of exstrophy and a neonatal closure without osteotomy. At 6 weeks, there is no upper tract dilatation and the bladder is seen. First UTI at 3 months with moderate upper tract dilatation bilaterally, distended bladder and dilatation of the ureter. Second UTI at 6 months despite antibiotic prophylaxis with slight increase of the dilatation and a full bladder. Third UTI at 14 months despite antibiotic prophylaxis, no micturition with stream seen by the parents, but only dribbling. The US demonstrates a distended bladder with dilated ureter and upper tract dilatation. So on the renal scans, you can see bilateral scars. The cystoscopy shows a large bladder, 2 large ureteric orifices, a regular tight bladder neck, and exclude urethral stenosis. The video urodynamics study shows a normal detrusor of the 120 milliliters, a bilateral low pressure reflux, and the compliance was difficult to evaluate due to the bilateral reflux. So in such case, what do you do? Either clean intermittent catheterization plus anticholinergics or reimplantation. So based on the workup, we concluded that it was a bladder in retention with inability to empty, and clean intermittent catheterization and anticholinergic were initiated. After 8 months, no UTI recurred with no dilatation of the ureter and minor upper tract dilatation. So this was the first case. The second case of dilatation of the upper urinary tract and UTI will be described by Professor Lottman.
Thanks, Thomas. Yes, this second case is a classic bladder exstrophy. It presents similarities with the previous one, at least apparently. Prenatal diagnosis, a normal postnatal renal ultrasound, closure on the first day of life without osteotomy, and uneventful postoperative evolution. Next.
Ouais, c'est bon.
During the first year of life, she was abroad, and she presented 3 episodes of urinary tract infection, febrile, and the parent described micturition with stream and otherwise dribbling. On ultrasound, you can see dilatation of the upper tract, dilatation of the ureters, and a semi-full bladder. She had a DMSA scan relatively close to the last episode of UTI, something like 1 month afterwards. There is a slightly asymmetrical distribution of the function, a smaller left kidney, and diminished uptake on the upper pole of the right kidney and on the lower pole of the left kidney. So we decided, as she was back to France, to do an evaluation under general anesthesia while she was 14 months. So this is the result of the closure. And at endoscopy, you can see wide open right urethral meatus. It was symmetrical on the other side, and an early high bilateral reflux. The bladder was smooth and with a fair capacity, we estimated around 100 ml, and good compliance as we could assess in this refluxing system. So we decided and performed the bilateral urethral reimplantation according to Jeff's. And since then, she is under follow-up. At 1 year, she had no more UTIs. On ultrasound, there was no more dilatation. And she is seen regularly year after year, every year with ultrasound. And she has volitional voiding daily, every 2 hours now. She has a functional capacity which is regularly increasing, but 2 years post-op, after reimplant, it was 100 ml. She has nocturnal enuresis, and on ultrasound, as you can see, there is no more upper tract dilatation. She obviously can empty her bladder, and on DMSA, there is still an asymmetrical stable function with a renal scar only on the left lower pole. GFR is normal.
Thank you very much. So in case of urinary tract infection and or upper urinary tract dilatation, investigation include bladder scan and voiding diaries to assess voiding volumes and residue, cystoscopy to exclude urethral stenosis, and video urodynamic study with a Foley blocked in the bladder neck to study the bladder capacity, the compliance, and any reflux. So what about the management? If you have a poor bladder emptying and a low compliance, either you can start with CIC and anticholinergics, but if it is insufficient, you have to do a Mitrofanoff and augmentation. But in case of vesicoureteral reflux with good bladder emptying and good compliance, you can start with deflux to avoid reopening of the bladder, or if not, reimplantation. So the goal number 3 of the webinar is to discuss the management of persisting incontinence. There is a consensus of the 3 centers for the management of persisting incontinence. To know if the bladder is favorable or unfavorable, a workup should include an evaluation of the renal function and a renal ultrasound, a quantification of the incontinence with PAD test, and a cystoscopy and a video urodynamic study with the bladder capacity and the compliance. The evaluation of the child and the family by psychologists and nurses is a key point to determine the motivation of the child and the social condition. In case of favorable bladder, a bladder neck injection of deflux can be tried, or more consistently, a bladder neck reconstruction plus a Mitrofanoff. In case of unfavorable bladder, bladder neck reconstruction plus bladder augmentation plus Mitrofanoff is recommended. So Marc will show us the results of the Kelly procedure in Nantes.
Okay, so this is our experience with the Kelly procedure since 2008. This Kelly has been performed in more than 100 patients, either with bladder exstrophy or proximal epispadias. As we mentioned before, at the beginning of our experience, as you can see on this graph, we used to perform postnatal bladder closure, followed by Kelly reconstruction at the age of 1. And in the last 5 years, we have decided to proceed as a single stage procedure, combining bladder closure and Kelly repair at the same time, ideally at 2 months of age. So the continence results I'm going to show you come from the earliest part of the cohort, and we included the first 20 cases of bladder exstrophy with initial successful closure, and all of them being now at least 5 years of age or above. Next. So the patient characteristics, these are 20 bladder exstrophy patients, 16 males, all had postnatal closure of their bladder plate, and the Kelly procedure was performed at the median age of 14 months. The bladder capacity preoperatively was assessed at about 60% of expected bladder capacity for age. And during the Kelly repair, we performed a reimplantation of the ureters in the vast majority of them. And most boys ended up with hypospadias. We had few early complications of the Kelly repair, few fistula, which surprisingly, all of them closed spontaneously, and some stenosis. Next. So these are the continence results obtained at a median age of 9 years. Again, this is the very initial part of our learning curve. We achieved some spontaneous voiding continence in 40% of these children, meaning 8 out of 20 are dry by day, wearing no nappies, no protections, and they are in underwear. 2 of them are also dry day and night. Interestingly, it's a very slow and late process. When you look at the same results, just at the age of 5, only 1 of them was dry. And it's only between 5 and 10 that they gain control on their sphincter, and eventually the bladder grow. When you talk about social dryness, it's something about 60%. It means those that void spontaneously, but also those that catheterize. An interesting point is that the Kelly procedure has not changed the proportion of children that will require eventually bladder augmentation. We have performed 25% bladder augmentation, and still at least we have 4 children that might eventually need an augmentation. So I estimate that the rate of children that will need bladder augmentation is something about 50%, which is not different from any other technique, I guess. And the CIC rate in our series is 1/3, either because they required bladder neck reconstruction or bladder augmentation, or both of them. Next. Obviously, a lot of these children will require additional procedures. Some of these boys have had their hypospadias corrected, and bladder neck surgery is an important point. 2 boys required bladder neck injection to achieve continence. We also performed either bladder neck reconstruction alone or in combination with bladder augmentation. And as I said, bladder augmentation was performed in 5 children and might be necessary in an additional 4 children. That's it for our results.
Thank you very much. So recently, the group of John Gerard published a paper in Journal of Urology investigating surgical approaches to urinary incontinence and long-term continence outcome after successful bladder reconstruction. Interestingly, 40% underwent bladder neck closure with continent catheterizable stoma, and only 25% of patients are expected to void normally per urethra without reliance on catheterization or urinary diversion. Henri Lottman will report his experience with bulking agent in the management of persisting incontinence.
Yeah, at the end of the 90s, we initiated a prospective study on the effect of a dextranormer-based implant to improve continence, particularly in the group of patients with neuropathic bladder or in the group of exstrophy and epispadias. And so in 2012, we reported the first results, and in the category of bladder exstrophy, we had collected 16 patients, and it became very early obvious that before any attempt of bladder neck repair, the success rate is just nil. And so we stopped injected patients who had not had a previous bladder neck reconstruction, particularly also because we did not observe any significant effect on the evolution of bladder capacity. But after a bladder neck repair, a significant proportion of patients can become either dry, almost half of them, or significantly improved, which means patients who do not require more than one pad per day, who are dry at night, and they are not seeking for any further treatment. So bulking agents may be useful, particularly in case of bladder neck repair, which has not reached a satisfactory results. But there are some conditions to decide whether you will inject or not inject the patient. If we can see the next slide. As it was shown a long time ago by Philippe Ransley already, if you scope the patient, and in males, if you have the verumontanum, which is into the posterior urethra, this is a good indication for an injection of bulking agent. But if the verumontanum is on the endovesical aspect of the bladder, sitting on the floor of the bladder, that is a poor indication, and in such condition, the patient should not be injected. In females, also, you need a urethra with more than 2 centimeters of length. Otherwise, it's useless to make an attempt of injection of bulking agent.
Thank you very much. So now El-ghoneimi will share 2 clinical situations of persisting incontinence. Case number 1.
Yeah, I would like to share with you the experience with these 2 cases. The case number 1 is a 5 years old. He had already his neonatal bladder closure without osteotomy, and then a classical epispadias repair according to Ransley without bladder neck reconstruction at 18 months. And he was still incontinent, voiding every 1 hour with maximum draw interval of 30 minutes, but no infection and upper tract normal. So we followed our strategy, and we did for him, the first is a flow meter, as you can see here. And you can see that he can void with, this is next please. And after voiding, we put him on the OR because to do a video aerodynamic, that was the first one, and which shows that he has no reflux and good bladder capacity. And next please. And in this case, we found that it was like a favorable, so we injected just the bladder neck with dextranormer, mostly to give an idea about a future bladder neck surgery for him. The video dynamic, which was done at the same sitting, showed at 8 years old, which means 3 years after, the injection bulking agent did not change for the clinical result. So the next urodynamic showed 125 milliliter with low pressure at 10 centimeter, with low leaking pressure. And when we did manual occlusion, the bladder capacity went up to 180 and still with low capacity and without reflex, as you can see on these curves and the X-ray. So in this case, he has a persistent incontinence in spite of the injection, and is 8 years old, and he is motivated to have a continence mechanism. So the evaluation showed that the upper tract is normal, but the bladder evaluation showed a favorable bladder, as the PAT test, he was having up to 180 milliliter of voiding, but the interval remained 30 minutes only, and the child and his family was very motivated to have a continence procedure with autonomous management. So in this case, we went to bladder neck reconstruction and Mitrofanoff. Next. This is 3 years after the bladder neck reconstruction and Mitrofanoff, and we can see that the amazing increase of bladder capacity for this child, which was just hidden by his incontinence, and it gives a bladder capacity now of 325 for 11 years old. He had 5 CIC per day by an umbilical Mitrofanoff, as you can see it, and he is dry with normal ultrasound and normal creatinine. And it is very important, especially with these dry children, to go and do systematically this videodynamic, and in this case, of course, without any general anesthesia, as it's done by the Mitrofanoff channel. But unfortunately, this child is not voiding anymore, but he is quite adapted to his social and school life.
So the second case?
The second case is a different scenario. At 5 years old, please. So he had exactly the same things: no osteotomy, bladder neck closure, neonatal, but he needed a uretrovascular implantation at 1 year old because of UTI, febrile UTIs, and he had his epispadias repair at 18 months. When we do epispadias repair without reconstruction, which means that we go a bit further than just a regular epispadias, but we don't do a typical bladder neck reconstruction in this case. He was totally incontinent at 5 years old, but without UTI and without any dry interval. Again, here we did his first evaluation, and you can see it is very clear that this bladder is a small bladder with 100 milliliter maximal capacity, but the most important, as you can see it in the curve of the urodynamic, that you have the pressure goes up very quickly to 50 centimeter water, which a very high risk for the upper tract with low compliance. In such case, he's still having an upper tract which is normal, creatinine is normal, but the bladder evaluation showed a not favorable bladder. So he needs to be managed, but we waited. You see that at 9 years, so we waited 4 years for this child that we decide to give him another surgery. Why? Because it was not adapted to his social life until the social life became adapted to the continence mechanism. So in this case, we did bladder neck reconstruction, bladder augment, and Mitrofanoff to be able to do it in the optimal conditions socially.
Thank you very much. And then finally, we want to stress the importance of continuous follow-up with this very interesting case.
Again, I'll share with you one of the cases that we managed and show that everything is not always going very well. So this girl, she was operated in her neonatal period, and she had a bladder closure somewhere else. at day 1 with osteotomy. She had recurrent febrile UTIs, so she had bilateral reimplant at 1 year. And then the follow-up, she was having just a repeated non-febrile like a cystitis, nocturnal inertia, so very small signs, and moderate daytime incontinence. She's just having pads with few incontinence. She was voiding by the urethra once per hour, but she had a normal upper tract and normal creatinine, and the family was very happy. The child was so happy because it was excellent reconstruction, but there was no follow-up after the age of 8 years old. And then we discovered this child at 17 years old in our emergency room. She's coming with a very high creatinine, nearly 500, and a true renal failure with all you can imagine, and severe dehydration and voiding by dribbling only, with total incontinence and severe bilateral hydronephrosis up to 46 millimeters of the AP diameter. And this is at 17 years old. At 8 years old, she was strictly normal. Next, please. So we managed her in emergency, just putting a dwelling catheter for 3 days, treatment of the UTI, rehydration, and all the nephrology management for her. And then we had her creatinine go down to 260 and remained at 260. So we put her on CIC every 2 hours and with anticholinergic and nocturnal indwelling catheter, and there was no leak between any CIC. So we did her first study 3 months after this treatment, and we can see that amazingly the bladder capacity was big capacity with low pressure, as the maximum pressure was 225 centimeter water, with average compliance, but no reflux, regular bladder, and tight bladder neck, as you can see there. So we kept her on follow-up, and 1 year after, you can see that the urodynamic remained the same thing, which is, you can see down there, which is up to 350, her pressure remains below 30 centimeter of water. Creatinine, of course, remained stable. There was no leak. The hydronephrosis went down, and the CIC is every 3 hours. So for this case, it just showed that we cannot leave a child without an aggressive follow-up, which means that with urodynamic, even at 9 years old, if she's doing well, and she should have been seen every year, either by ultrasound or creatinine, and now she's prepared for transplantation.
So thank you very much for your attention. Do you have any questions?
Thank you, everyone. So we've got some questions that have been coming through during the presentation. So I've just forwarded the first one on to you, Thomas. I think hopefully you'll be able to see it. If you look on the right-hand side, you should see a questions tab.
The discussions, questions. Yeah.
You can stop sharing the screen if you want to now. So
we don't have questions.
So I have one question. What is your experience on gland ischemia?
Why do you look at me? Well, I don't. Actually, obviously, all of these complex procedures, whether it is the complete primary penile disassembly repair of exstrophy or the Kelly, carries an intrinsic risk for the vascularization of the glands. I don't have any experience with gland ischemia because once you master the dissection, it's not that difficult to perform. What I do have experience with is some venous congestion at the end of the surgery, especially at the time of closure of the pelvis. Once you bring the two pubic bones together, it creates a compartment syndrome that might be responsible for venous congestion. which usually can be released by just putting off 1 or 2 stitches, and it's okay. But I never experienced arterial ischemia after this sort of dissection. Have you?
I think it's personally we did not have ischemia in our series, but we don't do total reconstruction systematically and routinely for all children, which means that if they are not favorable, as you said, and we are just tightening up the pelvis, and we can see that the color of the penis is not going well, and it's not in a good condition, so we don't do it. So I think it's more preventive than technique, but it can happen to anybody, and it happened. But I just want to underline one thing, that this webinar, we choose not to concentrate on the bladder, and for a future webinar would go through the genitalia, because this is an extremely important subject that we cannot just ignore it.
Yeah, and for genitalia, not only the short-term problems, yes, but also the long-term outcomes are very important to assess.
I must say that I have had a complete loss of the distal part of the penis in one complete primary repair of exstrophy, neonatal case. The baby was anuric for 3 days after surgery, and he had obviously low perfusion, not only of the penis but also of the kidneys. Fortunately for the kidney, the outcome was good, but for the penis, it was not that good, and this is one of the reasons why probably we should not do a complete primary repair of exstrophy in the neonatal period, but to delay it.
That's exactly the reason why we chose to do that, is because these are so complex procedures that
and
from the hemodynamical point of view, you need a very stable infant to be able to support this sort of surgery.
I mean, we repeat that we have never done total neonatal reconstruction yet. I mean, but I always say that we don't have ischemia lesion yet, which means we still need to be prudent.
Yes. Another question, dilatation of the upper urinary tract were congenital or secondary to reconstruction of the bladder? This is a very important question. I think that at birth, the kidney are normal. This is a very important point, and as you have to keep the kidney normal and undilated. So if you see dilatation of the upper urinary tract, you have to do something. It means the kidney may suffer. Another question to Henri, very nice umbilicus in your case. What technique do you use?
That's a good question, thank you. I do transpose the umbilicus with both umbilical arteries at the moment of the closure.
But that's something you do when you do the surgery at birth.
Yes, that's right.
Now that you are doing delayed,
that I will have to adapt myself and do that.
You have to think about it.
Yes, that's true.
And it's important also, if you are going to do the Mitrofanoff after this, I don't do any umbilical reconstruction for the first surgery, because I believe that most of these children will need Mitrofanoff, and I would create umbilicus with a Mitrofanoff inside.
That's a good point, because with the traction also of the appendix, when you do the Mitrofanoff, the cosmetic result is usually quite good.
Thank you. A question, how do you evaluate urodynamic study when you have vesico-urethral reflux? Any strategy on this?
Sorry?
How do you evaluate urodynamic study when you have vesico-urethral reflux?
Oh, that's a very good question. I mean, it's impossible, really. This is why, for example, in my case, I could just appreciate that the bladder had developed well, and there was no major defect of compliance in the system. But while you have a bilateral huge high-grade reflux, the only compliance you can assess is the compliance of the whole system, lower tract and upper tract. And it's only when the reflux has been corrected, then you can have a true evaluation of the capacity and of the compliance of the bladder. So usually, what was the difference between our two cases is that obviously in the first case, the bladder was in chronic retention. So the baby was dribbling constantly, but then every ultrasound, the bladder was full and the upper tract was dilated. In the second case, the baby was voiding, with parents describing the stream, and you could see that when you correct the reflux afterwards, the upper tract, 1 month post-surgery was completely normal, no more dilatation. And that's the difference. It's not a matter of compliance. It's very difficult to assess at that stage. It's a matter of the ability of the bladder to empty or not. The first case, obviously, the bladder did not empty. In the second case, the baby was voiding, the bladder was cycled, and it was mainly a problem of a high-grade reflux.
Thank you very much. Another question, have you observed worsening of kidney function as decreased eGFR or worsening of upper urinary tract dilatation after bladder neck closure, and what you have done?
Bladder neck closure is not routinely performed in a group. We have observed, in fact, quite serious upper tract complications when we did for a period when it was in the mood, if I could say, complete primary repair of exstrophy in the neonatal period. Really there, we had problems and we lost kidney function. This is why we have completely abandoned the idea of complete primary repair of exstrophy in the neonatal period. But otherwise, and it is really a key point of today's webinar, is to say a lifelong follow-up of our patients is mandatory. And if you follow your patients well, normally you can spare the upper tract.
I think the question means that if you don't have access anymore of the bladder neck because of cervicoplasty type 1 or closure,
yes,
and you have the dilatation, what would you do after? So the answer, of course, is, as we have, it's bladder augmentation. There is no bladder augmentation and Mitrofanoff, and I think this is not a failure of the strategy. It is to save the long-term kidney function.
But you should do the augmentation before you lose kidney function.
Exactly, yeah.
So question for case number 1, if the patient at age of 17 will refuse CIC to non-compliance, what will happen then with kidneys? It's a good question. How will you manage such case? So she was under CIC for her whole childhood and adolescence, and now she refused to do the CIC.
I think, can I answer?
Yeah, sure.
I think for these cases, it's exactly the scenario of all adolescents in congenital malformation and uropathy, which means that when they start adolescence and they refuse, you have to accompany them with nurses, psychologists, and you take them, sometimes who are more violent, and you take them to a dialysis center and to see that if they don't do the CIC, they will be finally in dialysis and with CIC also. So it is a failure of the certainly of the follow-up and the team and the relation between the family and the doctor and between the family and the adolescent. It is extremely one of the most difficult scenario and situation can happen, because of course you have to either to divert externally incontinent, and I think that when you really show the adolescent what is it, they accept to redo the CIC.
But the problem is that adolescents and late adolescents, when they want to get rid of everything, and particularly catheterism, is the moment where we also abandon them in a way. And this is why it is absolutely crucial to organize transition to adult urology units very, very well.
Exactly.
Because if you do not organize transition, this is the moment where you can see the patients disappear and sometimes coming back in a disastrous situation. And unfortunately, it is very difficult to follow up our patients after majority. And so this is a crucial point, that transition should be extremely well organized, and the patient should adhere to the transition.
So a question about the switch of strategy from stage repair to complete primary repair of exstrophy. Do you confirm this is a good choice? So as I said, we switch our strategy with two main objectives: to gather different teams after each bladder exstrophy closure, and to strengthen the training of the new generation of fellows. Do you think it's a good choice?
I think this is something that we have to be modest and humble. We thought when we created the government created the National Center for Rare Malformations, and we had the first thing we thought of, how can we improve the management of these children? And then it was very clear. In France, there were our friend Marc, he did this in all the west of France. So he became an expert, national, international expert of exstrophy, because of the good cohort and good cooperation with his colleagues. So even if you are in a great town like Paris, a great university like University of Paris, and then you have such a few number of new cases, how can you ask the young generations to build up their experience? It's nearly impossible. So in this case, to gather all the experience together, we keep that child in one center, and then all the others come and share with it. And then we cannot do such organization if you do a neonatal closure. So we kept to a delayed closure for this. It's not because we had complication with the neonatal. It is certainly we were nearly the last centers that they are doing neonatal. So if you see that all over the world, the majority are doing delayed closure, you have to be humble, you have to stop, and you say, okay, we have to move. So we did the delayed closure, and we have done till now, just in the last year, we have done now altogether four cases, even without the COVID disaster. And during these 4 cases is certainly our fellows, they have seen in these cases, all these cases and shared with it. So for that child, certainly it is, I believe it is better because he's well prepared, and then we have, of course, to advance and to evaluate prospectively.
Thank you very much. Question: how do you manage stenosis Mitrofanoff in the long term, and how do you manage incontinence if the patient is reluctant to augmentation and CIC? Marc-David?
Incontinence, if the patient doesn't want CIC or bladder augmentation, it has to be an incontinent diversion. Either you want to be continent, but you will have to catheterize and augment the bladder, because our primary goal here is to protect the kidneys. So that would be my answer, which is Alaa, I'm sure you agree.
I totally agree. I mean, if the child is not ready, or the adolescent is not ready, we have children that we augment them and Mitrofanoff at 12 years old, just because she was not at all asking for continence. And you have to speak to the child in this case. Of course, in a condition that the upper tract is good. We have sometimes to negotiate with the children and the adolescent. If the upper tract is bad, there is infection, there is reflux, there is incontinence. In this case, you negotiate that you will improve the umbilicus, and if you would do the bladder augmentation and
But we agree that incontinence in itself is not a problem as long as the children
at all. If he's doing well, if he's doing well with
I
incontinence,
cannot agree more with what you say, Marc, David. And the second thing is that renal failure should not be the price to pay for continence.
Okay, another question. Do you recommend urodynamic study on all patients and on what age?
Sorry, we did not answer about the problem of the stenosis of the Mitrofanoff stoma, which is a quite a frequent complication. And I think it depends on the degree of stenosis. Some of them you can just dilate them and add eventually corticoid ointment and leave a on-site catheter for a few days to dilate the skin, which is often the site of the stenosis. But when you have recurrent stenosis with a lot of fibrous tissue, sometimes you need to do a small surgical procedure to enlarge it again with a skin flap, usually a V-skin flap. Some other stenosis which occur due to false passage, for example, under the level of the aponeurosis are much more complicated to treat, but sometimes it is necessary to do a major procedure to eventually to reduce the catheterizable channel. But most of the stenosis are at the skin level, and they can be managed relatively easily.
So to answer about urodynamic study on whole patient or not, and at what age? Hi, David, your strategy?
Well, it's always difficult to perform urodynamic study in a child that is doing well and not asking for anything. So that's number one answer. And then video urodynamics is probably the method of choice at the age of 5, especially if they are still incontinent. I routinely don't do urodynamics in children that are continent with normal upper tracts without infections, but I know Alaa disagrees.
I totally disagree, because I think that you need to do urodynamic, especially in children who are continent and with normal upper tract, and especially and voiding, which is very rare. In our experience, it's very rare. I would believe that in our type of reconstruction, we wouldn't go higher than 10% that they are voiding. But if they are voiding and continent, these are the children who are really at high risk. You see, this girl that we saw, that she was continent, she's having some few drops somewhere, and upper tract is normal, everything's normal at 8 years of age.
Yes, but there was a gap of several years until she came back.
But
almost 10 years. So I think that if you follow them up carefully, you have signs like you said, she was dribbling, she was no more voiding when she came back with renal insufficiency. And personally, I would do video urodynamic studies under general anesthesia, mainly when there are problems or for evaluation of the bladder before continence procedure. But if the patient is doing well, you must follow them up regularly. And the main problem of your last patient is that she has been lost to total follow-up for almost 10 years. But when she came back, she was not in the same clinical condition as she was when she was lost to follow-up.
Of course, yeah, of course.
Okay, so one question about stones. Do you see stones in bladder exstrophy, bladder and kidney? We have one case in Vienna. So how do you manage stones in bladder exstrophy?
Yes, bladder stone is one complication that occurs quite often in mid-term or long-term in extrophy patients. Not necessarily augmented patients, but even in because they have some chronic residue of urine. Management of this bladder stone is not always easy, particularly when you have had a bladder neck plasty through which you cannot pass an endoscope, or when the bladder neck has been closed. But for sure, you need to remove the entire stone to avoid recurrences.
So one question, difficult question. Is there any predictive clinical factor at birth that may help to determine outcome? Size of the bladder, length of diastasis, age of surgery, reductibility of the plate.
Yeah. I mean, the one who's going to say precisely this, he will have the golden prize. But I think that Marc will agree with that. If you have from the beginning a very small bladder plate, and you will not be very optimistic about this bladder.
I agree, but on the opposite side, one could consider that a large plate is only an indirect sign of a large diastasis.
Exactly.
You know, in the series I presented you, I looked back at the original pictures, neonatal pictures of the bladder plates of the 4 children who had bladder augmentation. They had 3 of them had fantastically large bladder plates at birth. So a large plate might just well be an indicator of a large diastasis and therefore a poor prognosis. So truly, I don't know the answer to your question.
And
in the contrary, if I may add something, I think that the postulate that if you close the bladder early at birth and you put everything in the pelvis, and then this bladder will grow and develop normally while it is cycled and so on, was, I think, in my view, a false postulate, which led to all the many problems have been seen in the world of bladder exstrophy, and this is why it has been complete primary repair of exstrophy has been progressively abandoned worldwide. I think from birth it is already decided that the bladder will not grow whatever you do, and half of them about will not grow normally.
It may be predetermined because at least you need 2 things. You need the ability of the bladder to expand, but also to contract.
Yes.
And potential, and one relies on
and the compliance.
One relies on connective tissue, collagen probably, and the contractility obviously on muscle cells. So, and probably there is a potential for that we don't know at the beginning.
Certainly there must be a predictive factor, but there is research to be carried on that. But I don't know exactly how, but there must be a way while you do some kind of neurohistopathology on these bladder plates and to define criteria, but that has to be done.
So we have many questions. So one question, diastasis. Do you measure the pubic diastasis before bladder closure? And how do you verify the pubic closure during long-term follow-up?
What's the...
So do you verify the pelvic closure during, do you measure the distance in between the 2 pubis during follow-up?
Most of them, they would reopen a bit, but especially, but the one which when we do the external fixator and we try always to close it, totally close it, I mean, the symphysis pubis. But anyway, the purpose of this is just to provide an immediate postoperative period with a good healing without fibrosis of the perineum, of the muscles, pelvic floor muscles, and the upper tract.
So what age is better for reimplantation?
What age?
The age, yeah.
I believe that when you do a procedure that increases the infravesical resistances, like the cervicoplasty, doing a Kelly repair, I believe you need to reimplant. Now the question is it possible to reimplant? And I have to admit that when you do a delayed one-stage closure with a Kelly, it's possible to reimplant in only half of the cases. So then, in those that haven't been reimplanted, I would reimplant only if I have infections, of course, and if there is a small bladder not developing, not growing with a high-grade reflux. And I believe then that the lack of bladder growth is in part due to the reflux. But I wouldn't all the time go for a reimplant. It depends on the symptoms and the bladder growth.
One very interesting question. Marc, what is the long-term management of hypospadias in your cases?
Mm-hmm. As you may have seen, I've not repaired many of these hypospadias. Well, one thing which is debatable, I admit, is that not all of these children will need their hypospadias to be repaired, because I would say that the children in a perineal urethrostomy with the bladder augmented, it would give you a very nice access for catheterization. So why would you lengthen the urethra? So I think only the children voiding, standing with their native bladder without catheterizing and without augmentation really need hypospadias repair. And in those I have done, usually a two-stage does the trick with limited complications. But I completely admit that I have not repaired all of them, because I believe not all of them will need it.
But do you have any bladder exstrophy continent from down with bladder augment and with catheterization from the bladder neck? No. You would do it through the Mitrofanoff. None of the patients that would have a tight cervicoplasty that you don't want to touch it, with bladder augment I'm talking, I am sure that you would have put a Mitrofanoff at the same time. Mm-hmm. Right? Or?
Yeah, you may be right, but what do you think? I mean, when you do a CPRE in one stage, most of the time you will have to do an hypospadias as well.
But
so what are you going to do?
I think we have to approach the problem. I mean, if from the beginning you're saying that we have to do all of this to be able to have avoiding urethra, that's right. I mean, I mean the optimal result would be voiding urethra. But now we're going back from this voiding urethra. We're saying that most of the children will not have voiding urethra.
Not most, but some of them. I mean, those.
No, most of them will not have a voiding urethra.
Yeah,
that's right.
Yeah, 60%.
Yeah. So in this case, I think, to cut the urethra, to put it in a hypospadic way, this is something which is bothering us all the time if you do a total reconstruction.
Well, at least to answer the question, I try to put some glabrous, not hair-bearing skin at this position, and tend to do it two-stage.
So you would do two-stage with a buccal mucosa or something.
Yeah. In the delayed primary repair, complete primary repair of exstrophy, we would tend to cut the plate. We did that in few cases and use a technique described by Gérard Montfort, using the foreskin to lengthen the plate and tubularize it. And it was also shown by Margaret Backhaus-Strowska and it gives good results. But we have a very limited experience with that at this moment. But I think it's an option because the question was raised here. But mainly in this webinar, we wanted to focus on the bladder. But if you have a situation where you have an hypospadias meatus, one option is to lengthen the plate with the foreskin.
We have a question from a bladder exstrophy patient. He would like to know if the Mitrofanoff procedure will become less frequent in the future, and what your expectations are on that, and or what can be done more to avoid lifetime dependence on medical material for urinating.
Progress of medicine. I mean, when we were born, we could not imagine that we would walk in the street with a telephone which you use as a television, as a telephone, as a camera, and almost prepare your coffee in the morning. And that comes due to the progress of research and improvement. So I would never say to a patient that he will have to catheterize for all his life long. I would say you have to catheterize until we have a better option to offer. But I really, and I suppose we all really hope that there will come through the progress of medical research new options in the future, and it can come sometimes very quickly.
A question not specific for bladder exstrophy, but what do you do a C-section with umbilical Mitrofanoff? Professor El-ghoneimi, you always do umbilical Mitrofanoff. What is the strategy for C-section with the OBGYN?
When you do a C-section, the Mitrofanoff is always deviated, and it's not becoming anymore in the midline. I mean, the uterus is going up and it is deviating the Mitrofanoff. We did not have, we have interrogated the question many gynecologists, and none have said that it's less or more difficult if you put it in iliac fossa or umbilical. But of course, you have to insist of C-section, and you have to insist that a urologist should be in the room for the cesarean section.
The wound usually occurs in the augmented bladder, not in the Mitrofanoff, but certainly the urologist should be present under such circumstances in the room.
A question: what is the best tissue choice for bladder augmentation in case of exstrophy? Is there any something specific for bladder exstrophy?
I would give my personal experience when I learned from my mentor, Jean Monfort. At that time in the 90s, we have put 23 stomach in the bladder of bladder exstrophy because we thought that it was contracting and it would empty. And of course, we have abandoned this because of the many complications. So what we do now is just the most efficient bladder augmentation with an ileocystoplasty with a configuration of W-shaped, and as it has been described by the team of Mansoura from Egypt.
We use ERN mainly here in Leclair.
And you
Debré.
So we have many questions, and new question coming. What time is it? It's 7:20. I think that we will give you our take-home message to finish the webinar. So the take-home message. First, you have to bring the child to adulthood with reasonable objective, acceptable social continence, with kidneys as they were at birth. It means normal. So we have already discussed about that. Then the ability of the bladder to grow is the key. But the ability of the bladder to grow doesn't depend on the surgical strategy. This is very important. Third point, pediatric urologists are unable to make miracles, but they should avoid disasters. And as we said, lifelong follow-up is mandatory, and transition with adults is a key point. So thank you very much for your attention. The webinar is over. And
so Thomas, thank you very much, and everyone, gentlemen, for presenting today. That's really interesting. Thank you for taking so much time to answer all the questions. I was really have time to go through everything. So thank you everyone for attending and asking so many questions as well. I hope you found it very interesting. Just to let you know very quickly, this was recorded, so it'll be put onto our GoToWebinar and YouTube channels tomorrow. If you've got any other things you want to point out, please send them through to me, any questions. I think also check our website for future webinars. We have another pediatric urological one next week on that continuation of our aneurysmal malformation webinars. So please look on our website for details of that. Yes, thank you very much, and again, thank you, gentlemen, for presenting. It's really interesting, and thank you for taking the time to do it. So,
thank you very much, Darren, for your assistance. Thank you very much, and good evening.
Good evening to you. Take care.
Good evening.
Bye.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.